Good afternoon, everybody. I hope everybody is staying nice and cool out there up in the Northeast. We're hitting over 100 today. We're going to be going over the 2025 proposed rule and understanding the impact on MIPS as well as MVPs and ACOs moving forward. Today, I'm joined by our CEO and President, Lauren Patrick. Hi, Lauren.
Hi, Mike. Good to be inside today.
It is, it is. And I am Mike Lewis, the Director of Sales and Success here at HealthMonix. I do not know if we're going to have a significant amount of time to go over questions, but as usual, I will be getting back with everybody within a day or two after the webinar with answers to your questions. Please ask them. There may be opportunity for us to pop in questions throughout the presentation. So don't be afraid to ask them, but there's a lot of information in a proposed rule webinar. You can also see the handouts down the bottom of your screen. You could grab those handouts for today's presentation. You'll also receive them in an email format with a copy of the link of this presentation this afternoon. So today we're going to review a lot of measure information, a lot of information about the different programs. What are CMS's thoughts? Lauren's going to fill in some of the color commentary on what's going on. And then we will go through a bunch of slides and information. We're going to start out talking about traditional MIPS. We're going to then move into what it looks like with MVPs. And finally, we're going to look at what the differences and changes are with the APP. So just from the start here, we'll take a look at what CMS's objectives are. I think the big things to understand with these objectives are that they align with the Medicare Shared Savings Program and the quality payment program. So that's your ACO reporting that we've done, as well as the other accountable care organizations with the QPP, which is your normal MIPS program. They're trying to get everything to be the same so that providers and groups can go from one to the other, more changing from traditional MIPS into ACOs as they move forward. They want to make that transition as easy as possible. Increasing the participation in MIPS value pathways is a big step in getting clinicians and their groups starting to think about value-based care more than just the MIPS focus that's been for the last several years. And then continuing to develop tools for measuring and improving patient care to support the shift to advanced payment models. They are looking, this is new for this year that I saw in the proposed rules, building a future where patients have timely, secure, and easy access to their health information, but utilizing the FHIR standard. That is, the big buzzword for the year is the FHIR standard, very similar to big buzzwords like blockchain and before that, interoperability, digital measures, things like that. But FHIR is definitely mentioned throughout this entire platform or report. Implement a universal foundation of measures. I think we introduced those in previous calls, webinars that we had, but the universal foundation measures are measures that CMS has deemed appropriate across every patient population and that have a little bit more to do with moving towards ACOs and ACO reporting. And then there is a new performance reporting option, collection type, and that's going to be the APP plus quality measure set. Okay, so we're going to start off with QPP. So this is your traditional MIPS that we talked about in MVPs, but with CMS has three pillars that they've explained multiple times through this, but alignment, growth, and equity. We've spent a lot of time in previous webinars talking about the health equity and the adjustments that CMS is making so that more clinicians are looking to serve in underserved populations, rural healthcare, and so forth. That's their big push for health equity. But when it comes to alignment and growth, that's where we're going to spend a lot of time today discussing improving quality and health outcomes using that universal foundation of measures, driving higher value care, supporting the movement towards advanced APMs, increasing alignment to reduce burden. I think that you'll see throughout this entire presentation. And as I said, promoting health equity. Their plan is to introduce programs that would connect payment to performance for specialists in the ambulatory setting. I think that, what I've seen from this proposed rule is they started to listen a little bit more to those small or medium-sized specialty groups that have struggled to come up with measures, have struggled to participate in ACOs, and they're starting to think of how they can impact those specific groups and get them where they need to be. Introduce a program for physicians or other qualified healthcare professionals who are responsible for all the primary care of a patient. I think separating of the primary care and the specialist is redundant, I would say, at a minimum through this entire proposed rule. Couple easy slides here. Everything's staying the same when it comes to breaking down MIPS reporting, quality, improvement activities, promoting interoperability, and costs all have uh, the same exact percentage as they had in past years. The eligibility for a clinician to have to report MIPS is still 90,000 in Medicare Part B charges, 200 Medicare Part B patients, as well as over 200 covered professional services. So that has not changed at all. Performance threshold for QPP 2025. CMS settled on this 75-point threshold for performance. This is the fourth year in a row that they're going to go with the 75 points. After we heard previous years, we were thinking last year at the proposed rule time, it was 82 points for 2024, and they brought it back down to 75. So this will be the fourth year in a row with the same benchmark, as well as they've predicted that it will stay the same for a couple years after that. I believe I've read through 2028 that 75 is kind of the number they're looking at. While staying at 75 sounds great, because we have a target, we all know what it's going to be. I think what you'll find is with the reduction in measure options as well as measures being topped out, the cost category having a larger impact as they add measures, you're going to find that 75 is going to be a tough score to get moving forward. Lauren, I didn't know if you wanted to add anything to this as we talk about the complexity of MIPS.
Well, it's really a trade-off, Mike. So if we stay at 75, then either a lot of people are going to be above 75 and the incentives are going to be smaller, or it's going to get harder and less people will be above the 75 and the incentives will be greater. So it feels like CMS, while they're staying at 75, to your point, it is going to get harder, but they are doing some additional things that we'll talk about as we go through here to actually negate some of that. So we'll talk as we go through.
Great. Thank you very much, Lauren. So we're going to start off, break it down by each of the categories. So we just mentioned the four categories. We're going to start in quality, as that tends to have the most changes every year and the most impact on what you're doing on a daily basis. So to start off, we're going to keep the 75% completion threshold all the way through 2028. That means those that are reporting MIPS measures will need to have 75% of each individual measure. They'll need 75% of the total population for that measure that they'll need to have answers for. So the Mets or not Mets or exclusions. As far as the quality measure inventory that we have, you'll see, and what stands out the most to me is the number of measures dropping and dropping and dropping. if you took a look at this back in the early 2020s, so let's say 2020, 2021, there was close to 240, even maybe more measures that had options for you to report on. Now that number's dropped all the way down to 196. That's split through the different categories that you see up at the top. Those numbers aren't going to add up because many MIPS CQMs and ECQMs and Medicare Part B claims are the same measures. However, this 196 just gives you the total, making sure that they're only counted once. So we're adding 9 new measures as well as the removal of 11. We're actually adding only 8. That one ECQM specific measure is just a CQM specification that is being added. So quality measures that are new for 2020 5, and these are proposed for you. And just, I lay them all out here because it gives you the opportunity to look at what is available, and to also take this when you download the document at the end to give you something to work off of. The number of measures here that we have are mostly MIPS CQMs, as well as that one ECQM that I mentioned on the previous page. We do have two measures that are going to be patient-reported outcome-based performance measures. The one thing that I found very interesting, and I don't know if Lauren had comment on this as well, but they're introducing 7 new measures that are process measures, which is just mind-boggling to me that this is where they're doing, because they've continued to push QCDRs to do outcome measures. But Lauren, do you have anything to say on this?
Well, I think COVID is an obvious one, right? They want to make sure that beneficiaries are getting vaccinated for COVID. And vaccinations are a big push. When you look at the universal measures, when you look at the new vaccination measure, when you look at where they're going with the APP, vaccinations are a big deal for CMS. So that one makes sense. Um, for some of the other ones, I think they're looking for specialty measures in a lot of cases, and that's really where they're going with a lot of these. When we talk about MVPs later on, you'll see that one of the problems they have in building MVPs for all the specialties is they feel like there's a lack of specialty focused measures. So a lot of these are, going back into specialties. So I think that's why they're allowing them to go forward.
Great, thanks. Yeah, I find it, coming from the dermatology background, that they're replacing the melanoma recall measure with a melanoma recall measure. So that is pretty interesting. So you'll see on the next page that one of those measures that's being removed is the melanoma recall system. There's a lot of information on these slides, but I wanted to point out a couple of things that I found interesting. They're removing 5 of these measures for them becoming duplicative of other measures that are currently in the system, or they are combining, in the case of some of these measures like 144, they're changing 143, the oncology medical radiation measure, enough to include the information that they've been collecting on 144. So they are continuing that trend like they did last year with the immunization measures and the other measures that are out there that are combining multiple measures into one measure. So that is also hurting the number of measures that are out there. 2 of those measures that you can see uh, here as well are being removed, the 439 and 472, because they've become so topped out, because they have become the standard of care. So tracking them is not exactly a good way to move forward, because everybody is doing it and most of the scores are nearly perfect. But once again, getting rid of a ton of measures, including some that are very familiar to many of our users here at HealthMonix. So the proposed rule also has quality measures with substantive changes. I always kind of get a little bit of a laugh out of what a substantive change is. Sometimes it's as little as changing one code in the system, but sometimes it's a full development, basically almost of a new measure. I've highlighted a couple here that we're going to go over on the next page, as they had changes that I thought everybody should know about. There were some changes as well to measures that are only available in the MVPs. That's 112 and 113. That's colorectal and breast cancer screening. And then with CAPS, I don't want to spend a terrible amount of time on it, but they are planning on introducing the web as an option to administer the CAPS survey. It has been an option for a small group of ACOs and I believe practices in the last year as a pilot, and now they're ready to move forward due to the fact that there was a very high increase in patients participating in the survey because they got it through email. So there's a lot of opportunity to get the actual information that they want. So a couple of the ones that are have changes that I really think that everybody should understand are on this. There are measures like diabetes and documentation of medications, falls risk. These are measures that a very large majority of our groups use: controlling high blood pressure, use of high risk medication, dementia. There's a lot on here. I did want to call a couple of things out here. One, you'll see a lot of age changes as different rules and different standards of care come about. They've added new age ranges to the system. You'll see down at the bottom 493 and 497. I thought this was actually pretty interesting that the pneumonia vaccination, they're planning on dropping it from the age of 60 as the minimum down to 19. I'd love to read more about what that looks like from a health standpoint, but right now I found that very interesting. Measure 130, probably the most popular measure that people have been reporting for since the beginning of time, it feels like, is changing the measure to now include every patient. So all the way down in ages down to 0. So you're going to need to do the medication list for everybody. And then one of the interesting changes that elder maltreatment's now available for emergency care. I thought that was a miss in prior years probably, but they added it in for 2025, and I think that's just going to add another measure to emergency care providers who currently have a very limited supply of measures to choose from. So what do specialty measure sets mean? What do they look like, and why is it important? So the reason it's important is that there's limited measure choices for specialists where measure development has been pretty slow. I think a lot of the people on this call, as well as a lot of people that reach out to us regularly, is like, well, what other measures can I do? What can I do? And CMS has acknowledged many times during this proposal that there has been a significant lack of new specialist measures that were brought to the table. I think Laura mentioned that a little earlier. You'll see that they were all process measures that were brought to the table in CMS, but you'll also see that across the QCDRs as well. Limited measure choice is something that they are looking into, and hopefully, I think it makes a lot of sense to um, prepare these specialists to do what needs to be done, that they can participate in these programs and succeed. So you'll see the plan for CMS is to eliminate the 7-point topped out measure score for clinicians reporting certain specialty measures. They're going to implement a new benchmarking strategy for those clinicians. I'm going to go over that on the next page. What you'll also see is that there's developing the MVPs addressing multiple specialty measure sets. So introducing an MVP that includes some grouping of specialty measures so that multiple groups, let's say your different types of oncologists, instead of having all of their measures in an MVP separated, they could kind of put those groups together if they work in the same practice. I think that'd be interesting to see, and using these multiple specialty sets as a bridge as they move forward. You can see there are a number of changes to the measure sets that they currently have, as well as they are introducing optometry. I believe they're actually just separating optometry from its grouping with another measure set. So a little bit about the limited choice topped out measures. I find this to be really interesting. And I think where it really helps out to understand is that CMS actually is listening to some of the issues that are out there instead of making these changes as they go. They're planning a new approach for the benchmarking. So measures would no longer be capped at 7 points. These measures included would be scored from 1 to 10, and those that are at the 97th percentile are corresponding to 7.5 measure points. Now, we need to do some math and figure out where this lands and how this can help you as a organization or a provider. But these are the measures, the 15 measures that they're thinking about doing this for. I wouldn't be surprised if this group shrunk or increased as we get closer to the final rule and what they're looking to do. But this does give you that opportunity to hopefully score better on some measures that you've been doing without having the opportunity to really have other measures to report on. If you're forced to report on, 4 or 5 measures or even 6 measures for your specialty, and so many of them are topped out at 7, makes it very hard to succeed in this program. All right. We're going to move into improvement activities, which normally is the flyby during my presentation because there's no changes and there hasn't been changes in a very long time. However, in 2025, they are planning to do some changes for improvement activities. So first, let's get some of the little things out of the way, adding 2 new activities, removing 8 activities. You'll see removing that is a lot of activities they're removing, and modifying 2 existing activities. But that's not the big change. The big change is that CMS is aiming to streamline the improvement activity category and proposing to eliminate the weighting of the activities. If you'll see in there, there's high and medium weighted activities, and they are each worth different amount of points. And there's different ways to get to the number you needed to make sure that you are hitting on every single point that you could get for improvement activities. The reason they're thinking of doing this and the reason why they can do this is because they are eliminating a bunch of the medium weighted activities, as well as they are introducing new activities that are really the standard of what they want from organizations. So you'll see some significant changes in the inventory that they have, and then you'll also see that number really starting to shrink and solidify into a group of measures. You'll see in previous years we were well over 100 measures to choose from, and I think we dipped below that moving into 2025. So what you'll need from an improvement category standpoint is if you're a large practice doing traditional MIPS, you'll still need your 2 activities. If you're a small practice doing traditional MIPS, you'll do 1. If you are a rural provider shortage area and a non-patient facing or a non-patient facing, you'll have to do 1 activity. And again, if you are doing an MVP, you'll continue to do 1 activity as well. So really take some of the complexity out of improvement activities. What you'll see here are the proposed improvement activities and the changes that are in the system. Don't need to go into it in too detail, but you could really tell by the ones that are being removed. It's a bunch of medium weighted activities and ones that a lot of our groups have participated in year after year. So in 2025, you're really going to have to sit down and figure out what you're planning on doing for improvement activities moving forward. All right, I'm going to take a little breather and I'm going to toss it over to Lauren as she's going to dig more into the cost category.
Hi, folks. So, yes, I'm going to talk a little bit about the cost category as it's proposed for 2025. Oh, somebody took the highlighting off of my slide. Um,
Ah,
so
me,
the first
sorry.
the first thing that I wanted to point out is there are two existing measures that are changing in 2020 or proposed to change in 2025. One is the cataract measure. It used to be called routine cataract removal. They've taken the word routine off of it. And one of the reasons they've done that is because they found as they've dug into the data a little bit more that, they had sort of limited the set of cataract surgeries that were being included in this measure. And they found as they've examined the data that broadening it to some less routine sorts of cataract removals actually doesn't change the measure results that much in terms of, there's not a large variance. So they're including more procedures in the measure as it's defined for 2025. So if you see that measure in your 2023 feedback report or your 22 feedback report, just be aware that in 25, you're going to see more episodes of care showing up. The other one that they've changed is it used to be called STEMI PCI, and now it's just called the PCI measure. They've gotten rid of the restriction to make them just STEMI, and it's all inpatient PCI instances that will be included in the episodes there. So again, they've broadened the measure a little bit more. So those are the only two measures really with substantive changes. Just so you know, every 3 years, if a measure's been in the system for 3 years, it is a requirement that they go back and they reevaluate the measure and determine things in terms of changes. Otherwise, the measures pretty much stay the same for 3 years, unless there's an event like there was with the pneumonia measure where they pulled that out of the system. So having said that, they have replaced the pneumonia. They feel the pneumonia and respiratory instances within the hospital are still a significant amount of cost, and they really want to continue to monitor that. So they've instituted the respiratory infection hospitalization measure as a new cost measure for 2025. And then there are 5 other chronic conditions that they've proposed for 2025. They started off by looking at CKD and end-stage renal disease, and they realized that they also wanted a kidney transplant management measure as well. So there ended up being these 3 related measures. They're chronic care measures, so they will be over time. There's not like an acute instance that triggers this. We look at the relationship between a provider over time and the beneficiary to determine where to attribute that patient's care and then what to include in that measure. So those 3 are closely related. They're chronic condition measures, much like diabetes and COPD, and I think low back pain is also one that was instituted this year. So just be aware that those 3 will be new. And then in addition, there's a prostate cancer care measure and rheumatoid arthritis. The interesting thing about all of these measures is as they've gone through review, they have been, it's been less than a smooth sailing. There's been a lot of discussion around whether these measures are appropriate, how these measures are going to fit in. And in fact, for the RA measure, when they did the proposed rule, there was a lot of there were a lot of votes, I'm going to call them, to say that this measure should not be included. They feel like it's not as robust as it should be. It did meet the reliability threshold, so CMS decided to put it in. But if you work in the rheumatology field and you take a look at this measure, you may want to provide feedback to CMS because it sounds like it's sort of on the borderline of should it be a measure, should it not be a measure. I will stop my commentary there. The rest of the measures are all the same. So what CMS did when they looked at the cost category, and the cost category has been measured very differently than other categories in that the benchmarks are all determined after the fact. And when they looked at the average scores, they found that the mean was 59 points out of 100. And they felt that was really bringing down a lot of scores. So again, kind of like balancing that against the 75-point threshold, they feel like they want to potentially look at that and understand if it should be higher. So what they've done is, drum roll please, next slide, maybe. So they're proposing to modify the methodology for scoring starting this year, actually. The way it's been scored in the past has been deciles, where they take each 10% of providers to whom the measure is attributed, and they give the bottom 10% 1 point, and then the next 10% 2 points, etc. And what's happened is, because all of the cost episodes kind of bunch towards the middle, with a little bit of variance, your score really changes. So what they've done instead is they've developed a methodology based on standard deviations. So if you're at the mean, then you're going to get 5 points. And then if you're at 0.25 above the mean, you'll get an extra point, et cetera, et cetera. The idea is we're trying to not punish clinicians that are close to the 50th percentile, but just under it. So CMS has done a lot of evaluation with the data that they have, and they anticipate that on average, clinicians will see an extra 3.89 points for the cost category if you have at least one measure in 2024.
Great. Thank you very much, Lauren. I'm going to throw up a quick poll for everybody here. If you could take 2 seconds to answer it, that will be fantastic. So how do you plan on reporting for 2025? Just quickly, APP, MIPS, or MVP. That would be great if you could share that with me. Give it another couple seconds. If everybody could come in and do this, that'd be great. Great, thank you very much. I'm going to share. We had 65% of the people, or 64% of the people, share this. It looks like a majority are doing MIPS. However, MVPs and APP reporting are definitely much higher than they've been in previous polls that I have provided. So now we're going to move in to promoting interoperability. So nothing has changed. I actually read those exact words in the proposed rule. There is very little to no change at all. They are planning on changing absolutely nothing with promoting interoperability, which is great because it sometimes is the most difficult to understand as well as explain. Here, though, that you'll see on a promoting interoperability page, this is what it looks like. I combined a couple of the pages that they have in the proposed rule to show what's going to be required, as well as if you take an exclusion, where do those points go, so everybody understands where they are with the promoting interoperability. You'll have this in your slide deck to be able to look at. So we're going to jump right into MVPs. So CMS is pushing as many different people into MVPs as they possibly can. Their goal is to get everybody in some sort of MVP moving forward. More than 750 groups and individual clinicians registered for MVPs in 2023. I thought that was kind of interesting that they gave us the registered number and not the amount that's submitted, but sometimes they want to make the statistics look the way they want to make them look. Changes to the existing MVPs we're going to go over. There's a number of changes that are out there. Introducing 6 new MVP possibilities, which now they're saying that in those MVPs, 80% of all specialties can participate in an MVP. I'll be interested to see what that looks like from a total population rather than different specialties. But to me, that's a big leap from where they've been in the past. Update the scoring on population health measures. So taking a look at that, you have the use of the highest score of all available population health measures. In the past, you had to choose which measure you wanted to be included in your MVP at the time of registration, which I think in my last call, I thought that was kind of silly to do that. But if you look at it now, this change really makes sense. They'll take the highest of the two, so there's no guessing game played in between. MVP reporters also, when we went over the improvement activities, I shared that they only will need to report one activity, no matter the size of their practice. So, other changes in MVP reporting and what maybe the future looks like a little bit. So, with the development of new MVPs, they are planning on creating one that they're going to consider a cross-cutting MVP that broadly applicable measures that are out there. Mostly the reason that they're going to do this is that so they can combine the MVP, the specialty practices, having them the opportunity to report one MVP while the other measures, while they're continuing to ask for new measures to be in the quality realm so that they can do that. The quality measures, including measures like the screening for depression, high risk medication, screening for social driver health, as well as a longer list they had there. I just wanted to point a couple out, are in there because many different specialties and primary care providers can report on those measure types. Cost measures, so it would be a wide range. You're looking at TPCC and MSPB. And then collaboration is to create a bridge for clinicians without a current MVP option, giving them the opportunity to be part of MVPs, learn what the strategy looks like as part of MVPs, while working with these specialty societies and other groups to create measures that make better sense to include in future MVP and development. One of the call outs that they made, and I think is great, is the development of an MVP for non-patient facing MIPS eligible clinicians. So your radiologists, your pathologists, as well as some other specialties that are out there don't have an MVP. And one of the main, if not the main reason they don't have an MVP is that they lack a cost measure. And the way that CMS wants to do these MVPs moving forward, if they produced an MVP without an applicable cost measure, it eliminates the idea of why they wanted people to move to MVPs, and that is to help reduce the cost of care while improving the quality of care.
So,
So the
Mike,
next, oh,
one of
go
the
ahead.
other things I just
Mhm.
wanted to point out is I think CMS is doing this because they want everybody moved to MVPs ASAP. I don't know if you're going to mention this at some point, but in the proposed rule, CMS made it clear that traditional MIPS will not sunset before 2030. Um, and I think one of the reasons is they're having a hard time getting everyone transitioned to the programs that they want to replace it with. And one of those things happens to be the MVPs. So I think MVPs are getting a big push in terms of specialty measures and in terms of building these MVPs that really don't align with what we heard as the initial focus of an MVP, which was to be super specific about a specialty.
Great, thanks. So as I pushed further onto the next page, this goes into a little bit about what you're talking about. Now, the 2030 thing, they want them all in MVPs. CMS isn't getting rid of traditional MIPS until at least 2030. But from here, we kind of were scared last year, the year before, when they said mandatory subgrouping reporting was finalized for multi-specialty organizations for 2026 reporting. Well, they really didn't clearly state out, well, what does that actually mean? How am I going to split up my group? Do I have to report MVPs? Well, so let's start at the top. First, you do not have to report MVPs in 2026 if you're a multi-specialty group. But if you do choose to report MVPs and you're considered a multi-specialty practice, you will need to report as subgroups with the specialties broken out. So for single specialty groups, you may continue reporting MVPs at the group level, as well as reporting your traditional MIPS. For multi-specialty groups, you're going to need to submit through subgroups to report an MVP. Clinicians that don't have an MVP to participate in will either need to submit as individuals under traditional MIPS, or the whole group would need to report as well, the traditional MIPS as an entire group. And CMS will break out those subgroups if their scores are higher than the traditional MIPS. So CMS will provide the highest of those scores. Subgroup reporting will provide patients to find clinicians related to a specific condition, care of need. I think this is this is like the dream of CMS, is being able to provide patients with the information that they can use when choosing where to go for their care. Subgroup reporting will provide primary care physicians with also the tools it will take to provide accurate and good patient referrals based upon what the patient's needs are. Currently, their plan is to use PACOS to end Medicare Part B claims to determine your specialty. So, I remember when I would sit in and work with practices, sometimes those were wrong in in PACOS. So I would make sure that that's something that you make sure that is there. Physician assistants and other providers of the type who've always kind of been deemed as primary care providers, they're going to look into aligning those physicians within subgroups because their scope of work doesn't necessarily match their education credentials. They may be listed as a primary care nurse practitioner, for instance, and they work in a dermatology practice or a GI or a urology practice. And then CMS is considering not forcing small multi-specialty practices to split into multiple groups. That's new for this year that I did see. That would eliminate those same groups that do not have to report for PI to have the ability as well to not split into multi-specialty practices. So changes to existing MVPs, we'll kind of fly through some of this stuff here, but they are adding IA ERP6 to all MVPs. That is the new vaccine status for COVID, flu, and hepatitis B. I mentioned it on the IA slide that this is the measure that went from just having COVID to adding these other vaccines on there. They are adding the proposed new cost measures. So the slides that Lauren went over a little bit ago that included all of the new cost measures are now going to be part of the MVP categories. You can see here they're included to the cancer care, rheumatoid patient care, as well as the kidney health MVP on this page. The next page, very similar information. Just wanted to share a little bit here more. The one thing that I will say that changed a lot in the MVPs are what QCDR measures are included in the MVPs. You can see, for instance, the neurological conditions MVP is going to remove 6 QCDR measures and just add 2 of the MIPS CQM or MIPS CQM measures there. You'll see on this page, for instance, there are no changes in the cost. So what we have here are the proposed new MVPs, complete ophthalmologic MVP. I probably should have skipped trying to say that one, as well as derm and gastro are on this page. There's 3 more on the next page. You'll see the different types of groups that they're expecting to be able to report within these MVPs, as well as the number of measures, QCDR measures, and improvement activities that will be included in these MVPs. On the next page, you'll see the next grouping of them. I find this very interesting as I've come from the background of urology, dermatology, and GI from a pathology standpoint, and it's interesting to me that the 3 of the 6 new MVPs are kind of my bread and butter of what we're looking at. So I'm excited about looking at those opportunities and how it's going to maximize our groups when they are reporting. So now we're going to move over to the Medicare Shared Savings Program. So these are for the ones that are looking to move towards some type of accountable care organization or APM. A little background of what it looked like for 2023. There were 480 2023, sorry, 480 ACOs, as well as 634,000 healthcare providers that were part of ACOs. which is more than half of the providers that are in the United States are now part of ACOs in some capacity, and there's over 10 million beneficiaries that are grouped into ACOs, and they plan on that moving up close to 15 million in the next 10 years. CMS is proposing policies that are positioned to provide a path for practitioners to participate in the shared savings program to reach a goal of 100% of the traditional Medicare patients in a care relationship with an accountable care organization. Key markets for them are the markets in rural and underserved areas. As I stated before, they are high on high on CMS's aspiration for inclusion, as they are hoping that it can shift and promote health equity and inclusion moving forward. So introducing the new performance pathway, APP Plus. What you see on the left-hand side, just as kind of a scale of what we have, the number of ACOs that reported for ECQMs or MIPS CQNs has continuously grown. The first year was 12, then 37, then 73, and you can see the percentage in the peach color down the bottom. It has grown and doubled, more than doubled each year. So the APP Plus quality measure set is a new reporting pathway proposal for this year. You're going to see that it only includes collection types of ECQMs and Medicare CQMs. It will include the current 6 measures, the quality measures that have been around, and we'll go over what those are on the next page, and incrementally grow to include 5 more measures, so up to 11 measures in 2028. I think what you'll see is that I'll take proud of this, is that I said that they were going to be adding new measures over the next couple of years in my last webinar, and here they're adding the 5 measures more or less that I thought that they would be adding. There's been a lot of chatter about it, so I'm a little proud that I got these right. The new pathway is going to closely align with the Adult Universal Foundation measure set. We've talked about that a number of times. There's a lot of reading that you could do online about the Adult Universal Foundation set. It's going to allow practitioners to better focus on their quality efforts, administrative burden, and drive toward digital transformation. I think one of the big things that I see is that a MIPS provider is changing their measures, or is forced to change their measures year after year. And what they're trying to do is have the same measures year after year for these ACOs, and then building that into the Adult Universal Foundation measure set. It's going to align the measures with the value in primary care MIPS value pathway, so the MVP for value in primary care. You'll see that these are the same basic measures that are going to be part of it. What they're trying to do is get more people that are in traditional MIPS, move to the value in primary care MVP, and then move into ACOs. That's the path that they're planning for them to grow. And CMS believes the increased number of measures are going to reduce the burden of adopting new measures, because really, what is going to be the impact if you have 11 measures if you do poorly in one, compared to if you only have 3 measures and you do poorly in one? Lauren, anything to add on this slide while we're here?
No, I think that I think it's interesting that they're putting this in so quickly. In the past, they've been very slow to increase the measures for APP reporting, but they seem pretty intent on getting these aligned with the universal measure set across the whole CMS set of innovations and programs that are occurring.
Right. And I think, to be honest, if I were to guess, is that this will probably be pushed out a year or two, and them not getting rid of the MIPS CQMs in 2025. I think that's a big change that ACOs probably, will fight back on a little bit. I think that this is where it's going. I don't think it is going to be mandatory for next year like they are saying. So I'll be interested to see what the final rule says on this. All right, so let's go take a look at the measures that are available for the APP Plus quality measure set. You can see the top 6 are the measures that were around for last year. You have your CAHPS from MIPS survey, you got your 2 administrative claim measures, and then you have diabetes, depression, and high blood pressure. The plan is to bring back measures 112 and 113 that were eliminated from MIPS reporting and put it into the APP world. So they'll be very similar. For that, you'll see that each one of these measures will get the ECQM. I believe it's 305, 487, 493 aren't ECQMs at this point, but the plan is to be able to make them ECQMs over the next couple of years. And they say it takes about 3 years to change something into an ECQM. So they'll have the ability to report ECQM for those last ones there. But this slide goes over the performance year 2025, then what it would look like in 26, and then all 11 measures in 2028 and beyond. So here what you'll see is for the Medicare CQM. So we talked about ECQMs, we talked about MIPS CQMs and Medicare CQMs. So the Medicare CQMs that were introduced for ACO reporting in 2024, they are planning to move those and change the way that they are being benchmarked. The plan is to retroactively benchmark these starting in 2025 based on flat benchmarks for the first two performance periods. So in 2025, you'll have your regular measures that you see up the top that will now be included and have their own benchmarks. Then you see in 2026, they're adding more 27, 28, and 29. They'll have the ability to add those collection types and use benchmarks for each one of them, which will be interesting to follow as they're changing benchmarking methodology that has not been part of MIPS in the past. It's going to allow for high performing ACOs to maximize their scores and still leave room for growth year over year. So this is a little difficult maybe to read slide, but I did want to share what it looks like each of the years. What you're talking about, the big difference here is that you'll be able to report 5 measures, 5 ECQMs, the CAPS from MIP survey, as well as the claims-based measures in 25. Then it moves up to 6 and then 8 measures in here. And then what you'll see as you move further down is that each of these years, they're planning on continuing the ECQM Medicare CQM Achievement Health Equity Adjusted Score. It kind of lowers the ability for you to what needs to be done. So the first one here is this is the 40th percentile across all of them. That way you'll be able to meet your alternative quality performance standard and eligible for maximum savings, shared savings. And then the next group here is kind of that out that we've had in the past, but they're going to continue it where you only need to have in the 10th percentile on at least one of the 4 outcome measures, as well as being the 40th percentile for one of the remaining 7. Then the second to last one are those that have participated in these things, but are not performing up to the standards. They will not get fully penalized. They'll be penalized at a lower rate. And then anybody that fails to report any of the available ECQMs, Medicare CQMs, and does not administer a CAP survey will not be eligible for shared savings and will owe the maximum shared losses. So as we are coming close to the end of this presentation, please make sure that you get your questions in. Looks like we have a ton of them, so that's great. I don't think we're going to have a chance to answer them today, but as I said, I will get back to everybody. So key facts about the ACO and the proposed changes. They're planning on revising the definition of what primary care services to include, and that is going to be adding more HCPCS codes and CPT codes to include things like safety planning interventions, virtual check-ins, and direct care training services, as well as the other ones that you see here. They are also planning on establishing a complex organization adjustment for both virtual groups and APM entities, including those ACOs, where the ACO will receive one measure achievement point for each submitted ECQM. They must meet the minimum case minimum as well as the data completeness. ACOs will have to report on all the ECQMs for the performance years to get the adjustment. Those that are going to combine 6 CQMs, Medicare CQMs and ECQMs won't be eligible for it. Each measure can't exceed the 10 measure points, the maximum 10 measure points, and the adjustment can't exceed 10% of the total points for the quality performance category. The other small part, maybe not too small for some of the organizations participating, is that they're planning to sunset the requirement for an ACO to be terminated if their assigned population is not at least 5,000 by the end of the performance year. So as I'm getting ready to finish up and move along, anything else to add, Lauren?
No, I just want to say I know there's a lot of information in here. This is really thick, and it, we just basically wanted to go over all of the highlights. I see a lot of very specific questions in the chat, and certainly, as Mike said, the team will get back to you with answers regarding a lot of your specifics, but we'll have more to come. I know that, as I said, this is the highlight. Everybody needs to think about strategies in terms of how you're going to react to this. And of course, it'll change a little bit by the time the final rule comes out. But by all means, stay in touch, watch our blogs, and watch for additional webinars where we'll share more information as we get closer to the 25 year.
Great, thank you. So final statements here, main takeaways. CMS is listening to clinicians at the ACO level, the primary care level, and the specialist level. You'll see a lot from what the slides that I did is they're actually listening for once. I think some of the things that they're looking to do have great goals in mind for patients and for the clinicians that are doing it. We now know MIPS isn't going away anytime soon, as Lauren said. 2030 is the first year they could think about getting rid of it. There are more cost measures, and they are also pushing towards MVPs. You're going to see both of those things grow and grow and grow. And then the program has more complexity, but CMS is hopefully reducing the burden for each one of these groups. So how MIPS Pro can help you. We are best in class US based support and integration teams. We are doing all MVPs moving forward. We have the ability to track your cost scores as well as reporting for both Medicare CQMs and ECQMs through the ACO, as well as MIPS CQMs for MIPS. We have multiple QCDRs for different specialties, so please feel free to ask about that. You can shoot me an email or give me a call, the numbers that you see here, or just go visit our site at mipspro.com. Here's an example of what one of our dashboards looks like for our ACOs being able to report on the 3 quality measures that they have. And stay tuned for our next webinar. I'm sure we are going to put one on really soon. Thank you everybody for joining today, and everybody have a wonderful afternoon. Thank you. Thank you,
Thanks,
Lauren.
Mike. Bye-bye.